A 28-year-old Asian woman presents with severe, rapidly worsening swelling in her lower extremities. When pressed, the fluid-filled tissue leaves a deep, lingering indent. Her initial laboratory workup reveals two alarming numbers: a serum creatinine of 1.1 milligrams per deciliter and a urine protein-to-creatinine ratio of 6.5 grams per gram. That ratio indicates a massive nephrotic range protein leak. She is losing an extreme amount of essential protein from her blood directly into her urine, overwhelming her body's normal fluid balance. In a healthy kidney, the glomerular filtration barrier acts as a tight molecular sieve. It is designed to keep large proteins safely circulating in the blood, while only allowing waste and excess fluid to pass through. Her filtration barrier is actively collapsing. Identifying the exact microscopic mechanism driving this leak is the only way to stop the destruction and save her organs from permanent failure. If left untreated, uncontrolled inflammation inside the kidney's filtration units triggers the formation of dense cellular crescents. These crescents act like expanding pressure cookers inside the glomerulus, compressing the delicate capillaries before rapidly solidifying into irreversible fibrotic scars. As this scarring spreads from nephron to nephron, the ultimate result is total glomerulosclerosis, the complete hardening and death of the kidney's filtering system. The human cost of this structural collapse is end-stage renal disease, condemning the patient to a lifelong dependence on a dialysis machine to survive. The clinicians are now in a desperate race against time and fibrosis. To halt the damage before it becomes permanent, we have to look closely at the microscopic anatomy of the glomerulus itself. This patient is suffering from a devastating dual pathology, fighting a war on two entirely different fronts within the exact same glomerulus. This table outlines the 6 classes of lupus nephritis. The first front in our patient is Class 4, diffuse proliferative lupus nephritis, the most aggressive inflammatory phenotype. On this front, high-affinity anti-dsDNA immune complexes lodge themselves deeply into the subendothelial space. This triggers a localized complement cascade, detonating a severe inflammatory response that physically shreds the local endothelium. Looking back at the classification table, the second front is Class 5, or membranous lupus nephritis. Unlike the deep endothelial attack of Class 4, Class 5 is defined by massive subepithelial spike and dome deposits that physically accumulate on the outside of the filtration barrier. The sheer weight and presence of these deposits cause the delicate structural site cells to completely collapse. This physical breakdown of the barrier is the direct cause of her massive 6.5-gram protein leak. Survival requires to point pharmacological weapons that can simultaneously attack the inflammatory destruction of Class 4 and the structural podocyte collapse of Class 5. There is a cardinal rule when managing organ-threatening acute kidney injury. Physicians must never withhold life-saving immunosuppression to wait for a renal biopsy. The initial counterattack begins immediately by hitting the patient's system with a massive pulse of intravenous methylprednisolone. This steroid pulse rapidly saturates glucocorticoid receptors, paralyzing inflammatory NF-kappa B transcription and effectively freezing destructive cytokine synthesis within 24 hours. Alongside the immediate steroid pulse, the team initiates the second arm of the foundational attack, oral mycophenolate mofetil, or MMF, to establish a long-term siege. MMF selectively inhibits the enzyme IMPDH. This cuts off the de novo purine synthesis pipeline, ensuring that autoreactive T and B lymphocytes can no longer proliferate. While this combination of high-dose steroids and MMF shuts down the acute immune attack, it leaves the patient dangerously vulnerable to continued massive protein loss. The critical flaw in this standard therapy is structural. Stopping the immune system from attacking does not immediately repair the physical architecture of the collapsed podocytes. The latest clinical guidelines now emphasize triple therapy to address the physical damage that standard induction leaves behind. This diagram illustrates the triple therapy decision matrix. The first pathway adds the biologic belimumab. By neutralizing BATH, it starves autoreactive B cells, making it primary for extrarenal flares. However, the second path, voclosporin, is required for our patient because she presents with massive proteinuria. Matching the advanced drug directly to the specific clinical presentation ensures the treatment addresses the actual physiological failure of the patient. Voclosporin acts as a highly targeted calcineurin inhibitor. At the molecular level, it binds directly to the cyclophilin protein inside the kidney. This direct binding physically stabilizes the actin cytoskeleton within the damaged podocyte foot processes, causing them to extend and interlock into a tight, impenetrable seal. A major clinical advantage of voclosporin over older calcineurin inhibitors is its pharmacokinetic profile. It provides this robust structural stabilization without the burden of constant drug level monitoring. With the podocytes fully restored, the slit diaphragms seal shut, the glomerular filtration barrier heals, and the patient's massive protein leak is completely halted. Standard therapy is no longer the ceiling for treating lupus nephritis. To save the kidney, you must aggressively combine foundation immunosuppressants with targeted agents, utilizing voclosporin for proteinuria or belimumab for extrarenal flares.